for all the Academy members. So Jean-Francois and Keith have graciously agreed to do this. They work at Pfizer and were involved in a lot of the translational data around the renal program, Javelin program, and there was a publication or two that came out in the last probably 6 to 12 months, and so I thought it would be relevant for this group. Jean-Francois, we probably will have another person or two join, but I think in the interest of time, if you want to get going, we'll turn it over to you and go from there. Appreciate you doing this.
Thank you. Well, thank you for the opportunity and really appreciate being able to go a little bit in deeper discussion around those topics. So what I'm going to do, I'm going to be presenting, there are about 30 some 40 slides. So I think within the next 35-40 minutes I will go over and then open it for discussion. And alongside me there is Keith Ching, who is the computational biologist who has covered the two studies we will be reviewing today and can compare and contrast what was done, because the methodology utilized in the two studies are somewhat different, and also different from what some colleagues at Genentech are doing these days. So without any further ado, we are both part of Pfizer, on Pfizer stocks, and we're going to be discussing today axitinib, avelumab, and sunitinib in the context of clinical trials. And to mention that avelumab is co-developed between Pfizer and Merck KGaA. So in terms of the agenda item for today, we will start with the broad biomarker analyses that were done for the Javelin Renal 101 study, which is the comparison of avelumab plus axitinib to sunitinib in first-line advanced renal cell carcinoma. And then we will move on to another setting, an earlier setting, the adjuvant setting, with another comprehensive molecular analysis of the S-TRACK study, this phase 3 study of adjuvant sunitinib in patients with high-risk RCC. And then I'll present some conclusion and perspective. So first, with the Javelin Renal 101 study, the data were presented initially by Dr. Choueiri at ASCO 2019. Additional analyses and summary of all the analyses and biomarker for this study were published about 2 years ago now in Nature Medicine, and this will be the basis of this first part of the presentation. So Javelin Renal 101 was a positive study. The addition of avelumab to axitinib showed a longer PFS and higher overall response rate versus sunitinib in first-line treatment of these patients. And the analyses were undertaken to look at the baseline tumor tissue that was collected from the majority of the patients enrolled in this study. Quick look at the trial design. Nothing special. Patients were treatment naive. They had to have one measurable lesion. There was the requirement to assess the PD-L1 status of all the patients enrolled. And in terms of the endpoint, the primary objective was to demonstrate the superiority of avelumab plus axitinib to sunitinib in either PFS or OS in the patients who were PD-L1 positive as a first endpoint, and then if that endpoint was positive, it was further analyzed in the overall population, and if it was positive, that final analysis was deemed the final result. So a sequential approach in looking at the primary objective. Randomization 1-to-1, normal schedule for sunitinib, 4 weeks on, 2 weeks off, and therefore the 6-week schedule was mapped to the avelumab plus axitinib schedule. These were the results. On top of the table, the independent review committee assessments, and in the bottom of the table in a light blue, the PFS assessments and overall response rate assessments per investigator. Very similar, no major differences. What was important here is that when we looked initially at the PD-L1 positive group, a significant difference in PFS and overall response rate, which was also observed when we looked at the overall population. The ITT population, therefore, did not need to be stratified or specifically analyzed for PD-L1 status, and the indication that came with the approval of avelumab plus axitinib does not require the patients to be tested for PD-L1 positivity. The analyses that were performed, 2 IHCs first, PD-L1 expression and CD8 expression. PD-L1 was considered positive if the immune cells, the infiltrating immune cells, were positive at 1%. And for CD8, it was just based on the median value, either superior or inferior to this median value. More importantly, gene expression was performed for the majority of these tumors. You can see that we had initially 800 plus tumors. We had 720 tumors for which we were able to get gene expression profiling. And then the mutation was performed for 733 patients. Looking at the PD-L1 expression, you can see that as expected, based on the results, PD-L1 expression did not segregate patients who were treated with avelumab plus axitinib. On the other hand, when we look at sunitinib, the patients who were PD-L1 positive did worse than the patients who were PD-L1 negative. This is somewhat expected. And now when we looked at the hazard ratio, again, not positive in the case of avelumab plus axitinib, but definitely worse outcome with an hazard ratio of 1.6 almost, and statistically significant for sunitinib.
I'm sorry, can I ask a question?
Sure.
What is the biological mechanism for PD-L1 impacting sunitinib response?
So those patients actually are, if they were receiving no treatment, they would be doing worse. That's a poor prognosis factor. So if those patients do not have PD-L1 expressed immune cells, they are therefore not blocked and they can do their work in the tumor. While if they are expressing PD-L1, they are not able to do what they are supposed to, and therefore they cannot be promoting a tumor response in that setting.
Abhishek, here's how I think of it, rightly or not. I mean, PD-L1 positivity is a marker of inflammation, and we know, so it's probably a marker against an angiogenic phenotype, right, would be one way to think about it. That's how I think about it. So PD-L1 positivity probably predicts against response to some sort of VEGF targeted approach. I think we've seen that across many, many data sets, including this one.
And so if you I don't know if it will be relevant for these particular cohorts or not, but if you just stratify tumors based on PD-L1 status, do you also see transcriptional signature of hypoxia trailing with one cohort versus the other?
So that's Okay, go ahead.
I was just going to say, basically, what like inflammation probably is one way of thinking, but also in terms of a more immunosuppressive state in which the tumor cell is living in.
So we'll look into the signatures a little later in the presentation, and as I was alluding to, there is additional work that's being done by Genentech on different type of clusters that go towards this better definition of the different phenotypes that exist in these patient groups. Looking at CD8, CD8 expression, of course, if patients had a higher level of CD8 positive cells, they did better, and that's the darker blue line when they are treated with avelumab plus axitinib. On the other hand, a little less effect here, I would say. It's actually not statistically significant when we look at it. In the sunitinib arm here, the patients who had higher expression actually are lower in terms of their curve. We have data generated in a different clinical trial, which was the EFFECT trial, where it was the reverse with slightly significance. So I think depending on the patient's group, these data may or may not be replicated. But as expected for axitinib plus avelumab, this is trending in the right direction. So going into the gene expression analysis, which is a big part of this analysis here, the one thing that was done is to filter out different genes that were not either well expressed or expression was very stable regardless. So they were filtered out. About 4,600 genes remained in the initial filtering. Based on further co-expression analysis and without looking at where the treatment was, but just on clinical outcome, a module of 306 gene was extracted. This was further refined by looking more specifically which of those 306 genes were more closely associated with the clinical benefit that was seen in the avelumab plus axitinib arm versus the sunitinib arm. And then out of this, this final signature of 26 gene was subsetted, and these genes are characterized here. And again, this was driven to find immune-related genes. A similar approach was done, but not looking this time at the genes that were immune-related, but more at the angiogenic related genes that were more predictive of the sunitinib effects versus the avelumab plus axitinib effect. So first of all, looking at this immune signature, we can see here the effect as the model anticipated. When the patients have a higher expression of that signature in the avelumab plus axitinib arm, we have a group that derives very good benefit, and versus a group who has a lower expression of this signature and derives less benefit with an hazard ratio of 0.6, which is better than the original hazard ratio of 0.69. And then when we look in the sunitinib arm, again, no separation because this is really driven by the immune component here. On the reverse side, if we look at the angiogenic signature, as predicted, it does not separate the arms within the axitinib plus avelumab treatment patients. So regardless of the expression level, both groups are doing just the same. If we look at the sunitinib arm, on the other hand, we have this arm of patients with a higher expression of this angiogenic signature who's doing pretty good. And when we look at the median PFS, actually, it is trending in pretty close to what is seen in some instances with patients treated with avelumab plus axitinib. Now, looking at the other gene expression signatures at the time, the emotion 150 had read out and signatures had been generated. Those are the emotion 150 T effector, myeloid inflamed phenotype, angiogenic phenotype, and the T effector plus myeloid, which is the combination of the top two here. So when we compare the immune signature, which would be the T effector from the emotion 150 and the javelin renal 101 immuno signature, you can see that they behave relatively the same. No or limited effects in the sunitinib arm, but definitely predicting better outcome for patients when they have a higher expression of this signature when they are treated with axitinib plus avelumab. Looking at the angiogenic signatures, very much the same as expected. Patients who are treated with axitinib and have this higher expression of this angiogenic signature do better. And there is limited effect seen in the treatment arm with axitinib plus avelumab with either signature.
Dr. Martini, could I ask a question?
Sure.
This is Vincent. Of course, avelumab is also an angiogenic therapy. Axitinib is an anti-angiogenic medication. So why do you think it is that across these signatures, we only see effect for sunitinib, but not for avelumab in the angiogenic scores? Because in some case, both arms are being treated with an anti-angiogenic therapy, right?
Yeah. So the major element here is the proportion of patients who are PD-L1 positive, which is kind of high. And I think these patients are driving the effect due to the anti-PD-L1 antibody avelumab being given to the patients. And the component that avelumab is bringing is relatively secondary.
I see.
Yes, I think, Vincent, you answered your question. Both arms are getting an angiogenic agent, that are column roughly equivalent. So you wouldn't expect the angio signature to differentiate between those arms, and that hazard ratio is, in essence, exactly 1.
Okay,
Correct.
Right. That makes sense.
Looking at gene mutations or polymorphisms, here association with PFS. Quick look at some of the expected genes, such as PBRM1. Mutations did not segregate patients regardless of the arm. BAP1, usually patients treated with anti-angiogenic do worse when they have a mutation. And indeed here, this is the patients who are wild type, they do better. However, for the arm treated with axitinib and avelumab, they seem to trend doing just fine, even in the context of a BAP1 mutation. and of course VHL being more ubiquitously altered in this patient population, it does not have any effect. Some of the genes of interest that were specific to this study are depicted here with strong effects seen in the axitinib plus avelumab arm. They are depicted here and will be further looked at in further slides. And then just to pick up on some of the genes that will be relevant a little later, mTOR here, not much, while we know that these patients usually have a poor prognosis. It looks like they did not do too bad, regardless of the treatment arm they were assigned in, while patients who had a PTEN alteration, and most of them had either mutation or deletions, you can see that when they are treated with avelumab plus axitinib, there is a big difference for the patients who are wild type versus the patients who are mutated, while this difference does not seem to exist when the patients are treated with sunitinib. So definitely these patients are doing worse when they have PTEN alterations are receiving this doublet combination. And that's further illustrated here on those Kaplan-Meier plot. When we start with the PTEN on the right, you can see that the patients who are wild type with the lighter blue line do pretty well versus the patients who are mutated and definitely do worse, and this is significant. And on the other hand, when we look in the Sutent treatment arm, there is pretty much no difference. The two curves are really on top of each other. Now, looking at these other genes that were presented earlier, the scavenger receptor, the CD163L1, you can see that the patients who have the mutation in their tumor are doing extremely well, while the patients who are wild type, they are doing like the rest of the cohort pretty much, because that's the majority of the patients. Only a small fraction, 22 patients had the mutations, but these patients definitely had great outcome. And this is not the case with Sutent. There is not a real strong correlation between mutation and outcome here. They do a slightly worse when they harbor the mutation than the patients who are wild type for that gene. And when we look at DNA methyltransferase 1, very similar situation. Patients who harbor this mutation, again, about 22 in the avelumab plus axitinib arm. These patients who harbor the mutations do relatively well, or definitely better than the patients who are wild type. And this is not the case when we look at the sunitinib arm, where there is pretty much no difference between the patients with or without the mutation. So in summary, PD-L1 expression did not distinguish PFS benefit between the two within the avelumab plus axitinib arm. However, in the sunitinib arm, definitely there was a difference, and patients who harbor a PD-L1 positive tumor do definitely worse than the patients who are without PD-L1 expression. Patients whose tumor contain high level of CD8 positive cells did better. And this was true definitely for the combination arm and not so much for the sunitinib arm. Two novel signatures have been developed within this study with the methodology that was described. So it is a very much driven type analysis. It is very focused on what type of outcome is expected for these signatures. And we could replicate them and verify them in an independent study, which was the Javelin renal 100 study, the initial study, phase 1b, that looked at the combination of avelumab plus axitinib. And in this smaller study, the signatures behave the same way. Elevated expression of a published angiogenesis gene signature and other related gene signatures were associated with improved PFS in sunitinib arm, but did not differentiate PFS in avelumab arm. And finally, the significant treatment arm specific difference in PFS were observed with patients who had very specific type of mutations, and some did better if they had mutations, the patients with these 2 mutations here, while patients who harbored alteration in PTEN did worse when they were treated with avelumab plus axitinib. So these findings define molecular features that differentiate therapy-specific outcomes with immuno-oncology agents plus TKIs in first-line advanced RCC, and could inform patients' therapy strategies in the long run. As you know, and as we alluded to, the group at Genentech has published new clusters, 7 clusters, that might help identify further and refine further the phenotypes of the patients who are included in our studies. And these patients might respond differently to different types of therapies. These clusters have not been prospectively confirmed. However, they have been verified in different studies, and this has been done actually in the group of Dr. Chueri with data presented earlier last year at ASCO and again at KCS symposium. And lastly, for this study, another presentation was made back at ASCO 2021, and a manuscript is under development to look at blood-based biomarkers in serial samples and how they can further inform and refine the patient subgroup that were identified in this Javelin Renal 101 study. So we'll definitely have additional data published, I would hope, later this year. And the acknowledgements for the patients and the participating investigators. And again, this work is done in collaboration with colleagues at Merck KGaA. So now shifting gears and going into the adjuvant setting, this time purely anti-angiogenic with the sunitinib study STRAC. This work was published at the end of last year. So the background, this STRAC study was the only phase 3 study that was positive, utilizing different type of anti-VEGF targeted agents. That was definitely a major issue. We know that this adjuvant setting is definitely not used very much for anti-angiogenic. And reason being this confusion and difficulty of interpreting the data in together. And Merck with pembrolizumab came with a very positive study last year or 2 years ago. And unfortunately, since then, we've seen 2 other readouts of IO agents that were negative. And again, the confusion is further increasing in this space of adjuvant therapy in renal cell cancer. This is definitely a high unmet need. A lot of patients, if they are detected at stage 1 or 2, will definitely do very well after surgery and have no disease recurrence well over 5 years. On the other hand, for patients with stage 3 or 4 non-metastatic, the probability of developing additional recurrence later on is increasing. And we know that based on the UISS classification, about 15% of the patients with non-metastatic RCC who have undergone nephrectomy will be considered at high risk, and of these, over 60% will relapse within 5 years. So we've done additional work to try to characterize the patients who were included in this extract study. This was the study result for the main study and the separation of the Kaplan-Meier curves with an hazard ratio of 0.76 and a p-value of 0.03, so just significant. What we've done here is comparing different methodologies, looking at gene expression signature and mutations, and correlating with DFS. Whole exome and whole transcriptome sequencing was performed. We are utilizing the same platform as was utilized on the Javelin Renal 101 study that I just presented. So definitely we have ways of comparing from a platform standpoint. Gene expression, we definitely replicated these signatures that have been published. So we have a way of comparing. However, we came up with new signatures that are more geared towards this setting of adjuvant setting and geared towards either general prognosis factors versus more predictive factors for specifically anti-angiogenic treatment. So here are some of the data. First, looking at the mutations themselves. So as expected, the highest mutated gene is VHL in this patient subgroup. PBRM1 is also highly mutated. However, as you can see here, PBRM1 between the Sutent arm and the placebo arm did not seem to really differentiate benefit whether it was mutated or not. Slightly better if patients are wild type, but not really significant. Same thing for SETD2. Same thing for BAP1. But what was interesting is when we look at ARIAD1A, patients treated with sunitinib did better if that was wild type versus mutated. And on the reverse side, patients who were mTOR mutated, if they were treated with placebo, did worse, which is expected. This is a poor prognosis factor. However, when we look at patients treated with sunitinib, patients were not significantly impacted with presence of mTOR mutation. Now, looking at the mutations that were associated with outcome, more specifically, those are the top genes that were associated with outcome with sunitinib. Some are related to immune components, and some are related to chromatin homeostasis. So they are listed here. TEMIS, which was actually also found on the Javelin Renal 101 study, patients who are mutated do slightly better if they're treated with sunitinib, and something for the WDFY4. There are other genes on the chromatin homeostasis, so KMT2D. Here again, mutated do better when they are treated with sunitinib, while the wild type do better with placebo. So definitely a new set of genes of interest, very different from the ones that were identified in the Javelin Renal 101, even though some are part of similar class of gene of interest. Looking at tumor mutation burden, I did not show it. I didn't show it on the Javelin Renal 101 because actually it was not associated with differentiation in outcome, whether the patients were at high tumor mutation burden or not. But here, as you can see, there is a separation. This is the overall sample set for S-track. Patients who have a high tumor mutation burden on the lighter line do worse, and this is expected, while the patients who have a low tumor mutation burden do better. And this is mainly driven by placebo. As you can see, patients who had mutation actually did relatively well when they were treated with sunitinib. Now, looking at the signatures, as I mentioned, we replicated the signatures that were identified in the Emotion 150 and in the Javelin Renal 101 study. Here, this is an example of the myeloid inflamed phenotype signature from the Emotion 150. Patients who have a high expression of that signature, this is the lighter color line, do worse than the patients who have no immune inflamed phenotype. So definitely, again, this point that was discussed earlier, the patients who have this immune phenotype in general do worse altogether. And this is further demonstrated in this study. And when we look at the angiogenic signatures, so this is the first one from the Emotion 150. You can see that, yes, the patients who have higher expression, they do slightly better. It's not significant, but this is also true for the placebo arm, and it's somewhat known that patients in general will have more of this angiogenic phenotype do have a better prognosis altogether. And this is also seen with the Javelin Renal 101 angiogenesis with a very similar effect. When we look at the immune signature, the Javelin Renal 101 immune signature, no separation. Patients who have high expression of that signature do very well in both the Sutent arm and the placebo arm. And this is the same for the T effector from Emotion 150. And really the difference comes from this myeloid inflamed phenotype, where patients who have a lower expression of this immune phenotype, of this inflamed phenotype, sorry, do better when they are treated with sunitinib. So looking at signatures and how to generate signatures, this is another method of generating signatures. This was an elastic net combinatorial biomarker approach, looking at what was of interest from this transcriptomic analysis and what were the genes that were most associated with the response to sunitinib. So the model is trained only on the sunitinib arm, These are the characteristics that came out of this training model. This is 11 genes, the top 11 genes that really drive the model. They are listed here. When we apply this signature to the overall patient group, you can see that the patients who have a higher expression of that signature do worse. That's the lighter color. While the patients who are having a lower expression of that signature do much better. And you can see that the hazard ratio now is 0.23, which is much better than the overall study hazard ratio. And when we look within the sunitinib arm, we have a great separation, which is expected. That's how well the model works. We can get some great differentiation between patients who have a lower expression of that signature versus the patients who have a higher expression of that signature. These are the genes that are included in this signature, and I point to two of interests. TDO2, which is known to be part of the stromal component, regulating some of the immune response, and there are actually some either selective or not so selective inhibitors that are being developed against this target. So it will be interesting to see how they behave in this context. Also of interest is MERTK. So this specific tyrosine kinase is also part of the regulation of the myeloid cells, and they are definitely inhibitors that are already approved or almost there, definitely in development, that do inhibit to some extent MERTK, and there are newer inhibitors that are more selective that are entering clinical trial as well. So it will be interesting to see how these, in combination with other agents, might behave and help derive better benefit. We were able to verify this signature. So first we looked at the TCGA dataset for kidney cancer. You can see we can replicate very well the signature. Patients with low expression do better than the patients with high expression. This is for the PFS. This is also true for the OS. Very same trend. And when we look at the Javelin Renal 101's dataset applied to the overall study, regardless of treatment arm, you can see that we have, again, a good separation between the patients with low expression in dark versus the patients with high expression in light gray. And now when we stratify per treatment, we can see that the patients with the high expression who were treated with sunitinib do the worst, but the patients who were treated with sunitinib and had a low expression are doing pretty much as well as the patient treated with axitinib plus avelumab. So there is definitely a group of patients that derive very good benefit by just receiving this anti-angiogenic. So in summary, mutation in specific genes were associated with worse outcome in the placebo arm, but not so much in sunitinib arm. mTOR mutations are definitely a poor prognosis marker, as we've seen in the placebo arm here. And mTOR1 inhibitors are being developed. And I think that this is also relevant from the results seen from the Everest trial, where everolimus the trial was not positive, but definitely there are subgroups that seem to derive benefit, and I would not be surprised if looking at the obvious mTOR mutated tumors as well as potentially PTEN altered tumors might derive benefit from everolimus treatment. Immunosuppressive environment of micrometastasis at the nesting site is likely as important as the anti-angiogenic phenotype in identifying effective therapy in the adjuvant setting. And finally, addition of anti-angiogenic in the adjuvant therapy should aim at targeting some of the key other elements that we have identified here. So maybe MER or TGO2 or other elements involved in this myeloid inflamed phenotype. And definitely we can find better therapeutic strategies and more personalized approach for adjuvant therapy for the patients at high risk of recurrence. This was the acknowledgement. This was an international trial, and conclusion and perspective to wrap up here. So doing broad genomics and transcriptomics profiling can provide additional information beyond clinical pathogenic classification, but one should not discount the obvious. Again, mTOR, PTEN, I think is important. We have a lot of recent large data sets that are becoming available, and people are utilizing a whole lot of AI and ML. So we can generate a whole lot of gene expression signatures, but one needs to keep in mind that they need to be verified, and then eventually they will need to be prospectively validated. And this is very labor intensive, time consuming, and expensive from a technical standpoint. And it's definitely not ready for prime time for everyday use. And we definitely need to do better for the patients. Thank you. I'll take any questions.
Thanks, Jean-Francois. Appreciate that. It's really great data. And I'd say from a clinician drug developer perspective, I mean, these kind of efforts are really hard to do. They take a lot of work and a lot of people and a lot of time and a lot of money. And it doesn't always benefit the company directly. So we on this side appreciate you doing it. Let's see if anybody has sort of questions, comments on the data presented.
Hi, I'm Krishnandu. I have a question regarding the first part of your talk. So you said that high tumor burden is not a determinant factor in the Javelin 101 trial, right?
Right.
But normally immunotherapy works better in the high tumor burden patients. So do you think that addition of axitinib is countering the effect? Maybe you showed the data that for sunitinib it actually works opposite way, right?
So I think there is a caveat here. It's based on the actual tumor mutation burden median, not with a specific cutoff. So we have to always remind ourselves that, yes, patients do better when they have high tumor mutation burden, but what is the cutoff and what is the platform utilized? Here we have a whole exome sequencing approach, which is very different from what a foundation medicine is providing, and therefore cutoff would be very different. Overall, those tumors did not have a very, very high tumor mutation burden. So I think that's probably skewed that way, and that's probably why it does not have an effect in this specific study.
And another question regarding that angiogenic signature. So you thought that sunitinib works better in the angiogenic signature, but still means the PFS is better for the other group, right? If
Yes.
you see by the numbers, even if angiogenic signature sunitinib works better, it's better to treat them with the other group anyway, right?
Yes. That's definitely a fair comment, but I think that as things are as more opportunity are given to the patients and there is more profiling that will be done eventually, there are definitely questions that should be asked in terms of quote unquote treatment intensity. Does everybody need to receive a doublet therapy of an immuno-oncology checkpoint inhibitor with an anti-angiogenic? I think that definitely the data we are presenting could question that. There is definitely a group of patients that does just well with the anti-angiogenic.
Thank you.
Yeah, I think that the hope is that as we get more mechanisms and more drugs, we could tailor the therapies, right, to individual biologies. We're not doing that now. We're just giving them indiscriminately. So, Jean-François, do you want to comment? You mentioned the Genentech data set, which I was involved with a lot, but maybe key differences in approach. I don't know how familiar you are with their data. I'm sure you are, but I view them broadly similar. You know, our set of angiogenic genes and your set, but I don't know that that's really important, honestly. I don't know that which angiogenic genes you choose, the specifics are that important. I don't know, maybe this is overly simplistic, group them all together, but do you want to, I'm just curious your sort of thoughts on key differences.
Keith, are you on the call? Do you want to comment on that?
Yeah, so actually I'm not familiar with actually which genetic study.
That's the Emotion 150.
The cancer cell paper, the Emotion 151. It was basically bulk RNA-seq on, you know, baseline tumor samples, largely nephrectomy samples. And it was this NMR approach to find clusters, and the statistics around it are over my head, but it was basically a clustering approach of gene families.
Yeah, so the methodology that we had used for the Javelin Renal 101 study was to look at like correlated clusters of genes just based on the expression alone. So we used a weighted gene correlation network analysis. And so what this does is it finds clusters of correlated modules of genes. And then so the genes were clustered first, and then they were annotated as to what each of the clusters was. So one was a highly angiogenic cluster, and then one was the immune cluster that became the Javelin immune signature. So we actually had these larger clusters, and then they were tested for robustness by doing kind of like a leave out kind of analysis, and then just trying to see which genes would most robustly keep appearing with high frequency into the cluster. So these became kind of like the refined set of genes. So really the smaller set of genes were like kind of the most robust members of the larger co-expression cluster. And so that's kind of how these were defined. So they weren't actually selected. They were selected according to kind of like a, I guess it's more of like an unsupervised approach, and then kind of annotated after the fact, right? So what's the kind of the structure of the data, and then kind of like what do these clusters represent? So so that's kind of the approach that we took for that, right? Okay. And then you know, like for the elastic net type of methods, the question was kind of like, you know, what kind of combination of genes you know, could provide some kind of modeling, right? And I mean, in this case, you know, each of those genes actually represents a set of correlated features, right? Because a lot of genes are all correlated with each other, but the method will sort of pick a representative of you know, one set of those correlated features, right? So here, you know, those individual genes that actually represent a kind of like a set of genes, right? And some kind of biology, right? And so what we're trying to do is we're looking at spatial transcriptomics data now for RCC, and we're trying to map, you know, where are these different genes, you know, within the tumor microenvironment, right? Are they part of the tumor? Are they part of the stroma? Are they part of like immune cells? And you know, kind of what we've seen is that, you know, in like the STRAC11 model, a lot of those different genes represent all these different areas of the tumor microenvironment. So some are representing tumor, some are representing stroma, some are representing the immune cells. So it's really this combination of the different aspects of the tumor and the microenvironment that's associating with the response. And then maybe just another comment is that the signature in this case also incorporates positive and negative aspects of the model. So it's not only things that have high expression, but things that have low expression as well. So it's kind of taking both directions into account. And so it's really that combination of this is high and this is low, which results in the S-track score. And the score is what, that composite score is what's associating with the survival. So, and then I think we were really fortunate that across RCC that we had, multiple comparable data sets, because that sort of the danger of this method is like you get this kind of gross overfitting because it's really good at overfitting. But we're able to run it on 2 independent data sets, and so that we could use the full S-track study for the training, but then validate it on other cohorts that had kind of similar anti-angiogenic treatment. So so not all of the studies we can do that because we don't have the validation, and so it's a lot harder to kind of come up with a realistic signature. But I think in this case we were pretty fortunate that that we could do that. Anyway, maybe that's a long answer, but if you
yeah, no, I appreciate it.
Can I follow up quickly? You answered a couple of my questions about the validation part, but I had a question about and I'm partly coming at it from some of the same questions that we have for other targets of interest in our lab. Can you flip it, the model, in a different way? Can you now take your 11 genes or whatever 20 gene sets that you might have generated that are validating across cohorts, but then apply that to a completely unsupervised sort of a cohort, and then say, what are the odds that a tumor that fits with a very high score will be a responder versus a non-responder? In other words, with what certainty does the panel predict response? Right now, you have associations saying that in general these will behave better than those, but that does not tell you whether or not a person with a very high score in your gene signature could still fall in the other arm, right?
Yeah, so for these validation data sets, they were a pretty large cohort, and then the score is kind of median stratified, right? So yeah, we don't have an exact number. Right. So in a population, relatively high or low will separate. But for an individual, I'm not sure. Yeah, how to get that that exact
I'm thinking
number.
in terms of the breast cancer panel. I don't know. Brian probably knows the panel, right? The chemotherapy predictor gene panel that they have. In principle, that's kind of like a utopian goal, right? You want that for every therapeutic decision that you're making. That okay, if this gene set scores this threshold or above, I make this as my decision. If it's not, then this is my decision. So
Abhishek, I can tell you, I've done a lot of work around clusters for our optics study and trying to put individual patients into clusters, and it's exceedingly challenging. The informatics is several levels above my understanding of it, but it's not these aren't like such distinct buckets, right? There's overlap, and where do you draw the threshold, and how much of this versus how much of that? There's definitely a big gray area in the assignment, and you have to set something and say, well, we think this is good enough, but I'm sure as we move forward, we're going to be refining those classifications and the clusters, and realize that it's not as homogeneous as we think. So it's been a big learn for us, sort of going through this over the last 18 months. So it's I'm a lumper, so it's easiest for me to think about this as very clean and distinct, etc. But I think in reality, it's probably very messy.
So we tried to integrate the 3 data sets into one big data set of RCC. But we found that they were still kind of separating by the data source, right? So we had some integration problems. So we didn't want to kind of deal with that because we might create artifacts and stuff. So we thought, okay, let's just do each one separately and then try to compare the results. So try to avoid that that problem. So yeah, so it is, yeah. Part of it is, you know, one of them, you know, TCGA was done with a different technology, so the two clinical studies integrated better than with TCGA, but there were still issues that we didn't want to do that.
So I think we'll jump off, we're out of time. Really appreciate Jean-Francois and Keith, both of you guys taking the time to do this interesting data. Thank you, and congrats, and look forward to more. Thanks everyone for joining.
Yeah, thank you.
All right, take care. Everyone have a good day. Bye-bye.